Hi, everyone. We're going to get started in just a moment. I see people are still signing on. So I'm going to give it just another minute. We have well over 100 people signed up for this webinar. Okay, we have a lot of material to cover, so we'll go ahead and get started. Welcome, everyone, to the report from ASCO focusing on metastatic breast cancer with Dr. Maura Dickler. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at SHARE. So before the presentation begins, I'd like to tell you just a little bit about SHARE. We are a 40-year-old nonprofit organization that helps people through breast or ovarian cancer, offering the support of those who've been there. SHARE offers many services, including helplines, telephone and in-person support groups, and educational programming. Services are free of charge to all participants. And for more information, you can visit our website at sharecancersupport.org. All participants will be muted during the presentation. You're welcome to submit questions throughout. When Dr. Dickler finishes speaking, we'll open up for questions and answers. Questions that have been submitted will be read. Anyone participating by webinar can submit questions through the question pane in the control panel on your screen. So now I'd like to introduce Dr. Dickler. Dr. Maura Dickler is the Interim Chief of the Breast Medicine Service at Memorial Sloan Kettering Cancer Center. She's also the Section Head of the Endocrine Therapy Clinical Research Program and Associate Member of the Department of Medicine at MSKCC and an Associate Professor of Weill Cornell Medical College. Dr. Dickler is a board-certified oncologist whose clinical practice is devoted to the care of patients with breast cancer. She's currently the lead investigator in several clinical trials looking at new molecules as well as new combinations and improved treatments for metastatic breast cancer. In addition, Dr. Dickler is a co-investigator on many more trials in metastatic and early-stage breast cancer. She's a member of several medical groups, including the New York Metropolitan Breast Cancer Group, the American Society of Clinical Oncology, and the American College of Physicians of Internal Medicine. She serves on the National Cancer Institute-sponsored Cancer and Leukemia Group B Breast Committee, the ASCO Breast Cancer Education Committee, and the Endocrine-Related Cancer Journal Editorial Board. And as if that's not enough, Dr. Dickler is an ad hoc reviewer for several clinical journals, including The Lancet, the New England Journal of Medicine, the Journal of Clinical Oncology, Clinical Cancer Research, and Breast Cancer Research and Treatment. Dr. Dickler, we're so happy to have you. Thank you so much for your willingness to participate with us today.
Thank you, Christine. Thank you for that kind introduction, and I'm really happy to be with everybody here today and look forward to interacting towards the end of the presentation. So just to touch on what I thought were some of the highlights from ASCO in regard to patients with metastatic breast cancer, I'm going to start initially talking about ER-positive breast cancer. And I think one of the highlights in that subtype was the data presented on the cell cycle inhibitors, the CDK4/6 inhibitors. So that's the Paloma 2 trial and the MONARCH 1 trial. Also, there was some data presented on mutations in the estrogen receptor gene, or the gene called ESR1, and we're going to talk a little bit more about this, and I will describe in greater detail what this means. We're also going to touch on HER2 positive breast breast cancer. We're going to talk about the drugs that are already approved and some interesting data that was presented. And then we'll also talk a little bit about triple-negative breast cancer. And one drug that actually wasn't presented at ASCO, but I think is been out in the press and want to talk about, the Immune 132, and then some immunotherapy trials. So as many of you already know, breast cancer is really not just one disease. It used to be that we treated all types of breast cancer the same, and then we really started to understand that there were patients with hormone receptor positive breast cancer, patients with HER2 positive breast cancer, and then there were patients that neither are estrogen receptor positive or HER2 positive, and for better or worse, there is a subtype known as triple-negative breast cancer. And knowing this subtype really helps us to guide therapy. Now, this subtype determination is actually made by looking at markers on the surface of the breast cancer, and I'm going to show you some pictures about that. But really, the field is also taking a deeper dive, and we're starting to look more on changes at the level of the DNA and whether there are too many copies of one gene or whether there's mutations in the gene. So really even this breakdown of breast cancer into these three main subtypes is likely an oversimplification. So I mentioned hormone receptor staining and also HER2 staining is really performed on tumor tissue that's sectioned at the time of surgery, and they take a small, very thin section of tumor tissue and place it on a slide, and then use antibodies that are directed against either the estrogen receptor or the progesterone receptor in the case of this picture. And here, the stained cells that are brown represent breast cancer cells that are positive for the estrogen receptor, as you can see on the left, and positive for the progesterone receptor, as you can see on the right. So it's really the top panels are the ones that have estrogen and progesterone receptor staining, and on the bottom you can see that it's mostly a sea of kind of bluish purple cells. That's really the unstained nucleus. You really can't even differentiate very easily where the cancer is from the normal, whereas you really can in the panels where you see estrogen and progesterone receptor staining. So this is what it means histologically to the pathologist, and this is how the pathologist determines whether your tumor stains positive for the estrogen or the progesterone receptor. This is a similar staining, but now looking at HER2. And again, the brown, staining of these tumor cells is an antibody that can bind to cells that have the HER2 protein overexpressed on the surface of the cell. So HER2 positive is considered 3+ or very intense staining, which you can see on the left panel. And on the right panel, there's a little bit of brown staining that you can see here and there, which gets called focal 1+ by the pathologist, but this is not considered HER2 positive in that anti-HER2 therapy has not been proven to be useful in those patients. So I just wanted to give everybody a visual of what this really means. Patients can be hormone receptor positive and HER2 positive, or they can be hormone receptor positive, HER2 negative, or hormone receptor negative and HER2 positive, or negative for all three, which is the triple negative. And we use these subtypes to help us guide therapy. So for women who are estrogen receptor positive, we can use some of the anti-estrogen-based therapies like tamoxifen, the aromatase inhibitors, fulvestrant or Faslodex, and these drugs really target the estrogen receptor. And then we have new targeted therapies that we can add in addition. And we're going to talk a lot more about the cell cycle inhibitors. The mTOR inhibitors are drugs like everolimus or Afinitor. No new data was presented on that this year at ASCO, but we do know that some women can get exemestane plus everolimus, and that's an effective regimen. You can see for HER2 positive disease, there's a number of drugs, that are active: trastuzumab, and pertuzumab are monoclonal antibodies. Lapatinib is a tyrosine kinase inhibitor, and TDM1 is an antibody drug conjugate. And we're going to dive down a little bit further and take a closer look at each of those drugs. And then in triple-negative breast cancer, we mostly have chemotherapy, but there's a lot of ongoing investigation looking at new agents to treat that subtype of breast cancer. So what's new in hormone receptor-positive breast cancer? So while we're able to target the estrogen receptor pathway, and if you can see here in this picture, you see estradiol is a hormone, and it's the little green kind of hats, and the estradiol binds its receptor, which is this blue, darker blue shape, and when the estrogen is bound to its receptor, it causes signaling or growth of estrogen receptor-positive breast cancer. And the way I think about this is I think of estrogen as a key, and you can see the key and lock on the side that fits into really fits into a lock. And when you turn the key, you get signaling of downstream pathways that causes growth of breast cancer. And we know that interfering with that signaling is very effective treatment, and we can accomplish that with several drugs that are available. An old drug but still a goodie is a drug called tamoxifen, and tamoxifen is a key that looks a lot like estrogen and binds the same receptor, but it actually inhibits growth. It's a key that may have a few slightly different notches, so that it actually doesn't allow estrogen to stimulate growth in breast cancer. There's other drugs like the aromatase inhibitors, which is anastrozole, letrozole, or exemestane, and these drugs actually work by lowering estrogen in postmenopausal women. And you say, gee, why do postmenopausal women have estrogen? Well, they do, and we make estrogen after menopause by converting androgens such as testosterone to estrogen, and these drugs lower that production, and so we make postmenopausal women supermenopausal. We also have drugs like fulvestrant that actually degrades the estrogen receptor. So it does away with the lock, so that it doesn't matter if there's a lot of keys that are around, but that they can no longer bind the lock. And these are some of the major endocrine therapy drugs that are used for ER-positive breast cancer. How do we decide if we're going to go with endocrine therapy versus chemotherapy? Well, we consider a number of factors, such as the burden of the disease, whether there's a lot of liver metastases and lung metastases, or is it mostly soft tissue and bone, and also whether patients have symptoms from their disease. Some women can have liver metastases and feel well and have absolutely no symptoms, and other women may have pain and lab abnormalities that show their liver isn't working as well. Other ways that we decide chemo versus endocrine therapy is whether they're HER2 positive or not, because if HER2 positive, we tend to offer anti-HER2 therapy initially as opposed to endocrine therapy, although some women get a combination of both. We consider menopausal status. In a premenopausal woman, we usually want to stop their ovarian estrogen production, and so that's important. And then what women have had in the post-surgical setting or the adjuvant setting also impacts what we might offer for women with metastatic disease. So a woman who's previously received tamoxifen and or an aromatase inhibitor and then develops recurrent metastatic disease will be offered a therapy that will take into account what she previously received in the adjuvant setting after her surgery. Well, we know these anti-estrogen therapies work. However, they don't work forever in the majority of patients, in that the breast cancer cells often learn to regrow despite our anti-estrogen therapy. And we're getting a better understanding of how the breast cancer cells are changing in response to treatment and what is causing them to become resistant. And so there's a number of mechanisms of endocrine therapy resistance, and one of them is thought to be mutations in the estrogen receptor gene, and another one is thought to be changes in the cell cycle survival pathways, and we're going to talk about those specifically. So I want to start with the role of CDK4/6 inhibition in breast cancer, and this is really those cell cycle inhibitors such as Palbociclib or Ibrance. We know that estrogen receptor positive breast cancer is dependent upon many of the proteins in the cell cycle. And if you look at the diagram on the right, essentially, if you remember back to biology, all cells grow, which is this G1 phase, and they have to make a decision as to whether they're going to divide or whether they're just going to hang out. And there's actually a checkpoint or a stop sign at these various important decision trees. And there are a lot of proteins that help a cell decide whether it's going to stop and hang out or whether the cell is going to advance forward and make more DNA in preparation for the cell to divide. And we call this the cell cycle, and we call these stop signs checkpoints. And so therefore, these drugs are really cell cycle checkpoint inhibitors. And we actually are trying to reinstate the stop signs, because in cancer, cells actually learn how to evade the stop signs. They go right through the stop signs, and we're trying to really put back stop signs and traffic lights in cancer cells. And one of the drugs that helps us do that is the drug called Palbociclib. It actually inhibits important enzymes that allow the cancer to cheat and go through the stop signs. And so really it's reinstating the checkpoint or putting the stop sign back in place. And Palbociclib was really the first cell cycle inhibitor that was FDA approved, and it was based on the Paloma 1 trial, which was a relatively small 165 patient randomized phase 2 trial where half of the women got letrozole plus Palbociclib and the other half just got letrozole alone. And for the women who got the combination, the Palbo plus letrozole, their median progression-free survival was double that of just letrozole alone. You can see the average person took 10 months for her cancer to regrow on just letrozole, and that was doubled to 20 months based on this small randomized phase 2 study. And this trial was enough for the FDA to grant approval of Palbociclib in February of 2015. Since that time, another trial was reported, the Paloma 3 study, which showed that Palbociclib also improves progression-free survival when added to fulvestrant, which is an intramuscular injection that causes degradation of the estrogen receptor. And you can see here women who got fulvestrant plus placebo had a median progression-free survival of almost 4 months, and this is in the second-line setting after all women had already had progression on an aromatase inhibitor. And in combination with fulvestrant plus Palbociclib, the median progression-free survival went to 9 months. And this was a highly statistically significant result and reassured us that FDA approval of Palbo was appropriate. At ASCO, another Palbociclib-based study was reported, the Paloma 2 trial, which really confirmed the results of the Paloma 1 study. It was a large, randomized, placebo-controlled trial where more than 600 women who were postmenopausal and ER positive were randomized either to letrozole plus Palbo versus letrozole alone. And you can see here that the median progression-free survival went from 14.5 to 24.8 months. So it really just confirmed the results of the Paloma 1 study and reassured us and the FDA that they had made the right decision in giving Palbociclib FDA approval right when the early results were available. And this is a forest plot and that just looks at the various subgroups of patients that were treated. And the bottom line of this slide is the patients who got letrozole plus Palbo all did better no matter their age, their race, their sites of metastatic disease, Whether they had measurable disease or prior chemotherapy, combination treatment was better over letrozole alone. And this slide just shows a comparison of the Paloma 1 trial, the smaller study of 165 patients, to the larger study of 666 patients with very similar results. And so that's really very reassuring. And it's nice that we have had the ability to give this drug in combination for now more than a year. We do know that there are added side effects when we add palbociclib to endocrine therapy. The one that's most common is lowering of the white blood cell count, which is called neutropenia. Most of the neutropenia is asymptomatic, meaning that it's a lab abnormality, but that patients who are on palbo generally feel well and are unaware that their white blood cell count is low. However, some women experience fatigue, and a small proportion of women do tend to get more low-grade infections like colds and sinus infections and things like that. And that's really the main side effect of palbociclib. I've also noted in my patients that there is more hair thinning with the combination than with letrozole alone. So now when I'm treating patients, I consider using letrozole plus palbociclib in the first-line setting as the first treatment when patients develop a recurrence of ER-positive, HER2-negative metastatic breast cancer, and it can also be used in the second-line setting in combination with fulvestrant. There are trials that are ongoing with palbociclib. The one that I think is most interesting is the PEARL trial, and that's going to test palbo in the third-line setting in combination with exemestane, and it's going to compare the exemestane-palbo combination to chemotherapy, because in the third-line setting, some women are not going to respond to another anti-estrogen treatment, and this study is designed to see if palbociclib can make exemestane work better, or do patients really need chemotherapy at that juncture? And I think that this is a very important trial that's currently recruiting patients. Palbociclib has been so effective and relatively safe and well tolerated that a large study is ongoing in the adjuvant or postoperative setting before women develop a recurrence of their breast cancer. It's called the PALLAS trial, PALLAS, that will randomize more than 4,500 women who have hormone receptor positive, HER2 negative stage 2 or 3 breast cancer to their endocrine therapy and palbo or not for 2 years. And this will be an important trial for the early stage setting. Moving along, there are other cell cycle inhibitors that are available. One of them is called Abemaciclib, which is made by Eli Lilly, and there's a red box around the Abemaciclib because data was presented on Abema at ASCO. And there's also Ribociclib, which is a cell cycle inhibitor that's made by Novartis, and there are many trials ongoing with really all three of these drugs. The MONARCH 1 study was a phase 2 study looking at single-agent abemaciclib, so just abemaciclib given alone without an endocrine therapy in hormone receptor positive, HER2 negative breast cancer. And this trial actually enrolled a group of patients who had previously received at least one chemotherapy, and many had had 2, but no one had had more than 2. And the reason they moved forward with this study is because a phase 1 trial trying to learn about dose and schedule showed significant activity of abemaciclib in a heavily pretreated population of patients. This is what we call a waterfall plot, and the bars beneath this line, each one is a patient, and the longer the line, the greater reduction in tumor for women treated with abemaciclib. So everybody below the line had some shrinkage of their cancer, and a shrinkage of 30% or more is considered a partial response to treatment. And so early phase 1 testing showed that this drug was promising, and the MONARCH 1 trial was really designed to confirm that. And all of these patients had previously been treated with a taxane-based chemotherapy. And if we go back to studies that looked at other chemotherapy in this setting, trials that have looked at capecitabine, ixabebolone, and eribulin, which are all approved in this setting, have shown response rates in the range of 10 to 20%. And we really need to be doing better for our patients. And so this trial really tried to look at abemaciclib in this population where everybody had already had a taxane, meaning paclitaxel or docetaxel, and we were really trying to beat that 10 to 20% response rate. And this is just the design. The abemaciclib is an oral treatment that's given twice a day, and patients were treated until unacceptable side effects or progression of disease. And the primary endpoint of this trial was response rate or tumor shrinkage. And here's another waterfall plot from the MONARCH 1 trial. Again, each bar represents a patient on the study, and anybody who is below the main line had tumor shrinkage, and the length of the bar is what shows how much tumor shrinkage women had achieved. The dotted line is that 30%, so anybody who had 30% or more of tumor shrinkage is considered to have had a partial response to treatment, and the overall response rate, which really adds up the percent of patients that had at least a 30% reduction, was almost 20%. So it's really as good as chemotherapy when you compare these results to historical trials. There were many more women who didn't quite achieve that 30% reduction in size of their cancer, but that even after 6 months of treatment, they still had what we considered stable disease. And when you add up the responders plus the patients who had stable disease for 6 months, the clinical benefit rate was 42%. And that's actually a very reasonable comparison compared to historical controls. This is a swimmer's plot. It looks like patients swimming in their lanes in a swimming pool. Each line represents a patient. And this just shows the duration of response for each patient, in that the patients who have been the long line to the patients who remain on study and have been on trial for a long time. For these types of drugs, it took a little longer for patients to achieve that 30% reduction. So whereas chemotherapy causes quick shrinkage, cell cycle inhibitors take a little bit longer to work, and the median time to response was 3.7 months. And for the women who had that major shrinkage, it was durable in that it lasted almost 9 months. Median progression-free survival was 6 months, and many women were doing really well in terms of overall survival, in that the median was almost 18 months, but this was only based on a fraction of women, as many, many women in this trial, the vast majority, are still alive, and we'll get more data on overall survival. This drug, abemaciclib, also can cause lowering of the blood counts, but what was really noted more commonly with abemaciclib compared to palbociclib was diarrhea. And the diarrhea was severe in almost 20% of patients. That diarrhea does respond to a hold or a dose reduction. It happens very early, initially with the start of treatment in the first 1 to 2 weeks, and is something manageable, but something that we really need to educate physicians and patients about, and also, what to do should someone get the diarrhea. There's a lot of interest in abemaciclib, particularly after the MONARCH 1 results were presented. There are a number of studies that should be reported soon. The MONARCH 2 trial and the MONARCH 3 study are studies using endocrine therapy with or without abemaciclib. There's activity of these agents in ER-positive and HER2-positive patients. So for a patient who is ER-positive and HER2-positive, she may be eligible for the MONARCH HER trial, which is a study that will look at abemaciclib in combination with trastuzumab or Herceptin. And then abemaciclib may pass through the blood-brain barrier, and may be useful for patients with brain metastases. And so there's specifically a trial of abemaciclib in women with brain metastases. So recently, we have come to understand that women sometimes develop mutations in the estrogen receptor gene, meaning the DNA that encodes the estrogen receptor. We all saw the brown staining on the surface of the breast cancer cell, and that surface staining is actually staining the protein. But all proteins start with DNA to RNA to protein. And we're recognizing in the DNA that there are changes in the DNA code that really makes up each gene in our body. And we believe that these mutations are not initially in the primary cancer at time of initial diagnosis, but are required mutations, meaning the cancer learns to mutate in response to anti-estrogen treatment. And when you get this mutation, you can still be responsive to anti-estrogen therapy, but the estrogen receptor takes on a different shape, and so it's harder to turn it off. And I think of the estrogen receptor as a pathway that may be firing, the way you might think of a dining room light that's on, and you can shut off a dining room light with a dimmer switch so that the light goes completely off. But if you have this estrogen receptor mutation, it may be that the light continues to shine at a low level, that there's still activity of the estrogen receptor, even when there are low levels of estrogen. So you have to think of the activity really of all proteins is probably on a spectrum, like a dimmer switch and a light. And should you have an ESR1 mutation, it may take a little bit more to turn off that dimmer switch. And data was recently reported showing the effect of ESR1 mutations on response to some of our anti-estrogen-based treatment. And here, this graph shows patients with ESR1 mutations who were randomized either to the green line, which is exemestane or an aromatase inhibitor, or the black line of fulvestrant. And for the women who have the ESR1 mutations, it seems like they may not respond as well to the aromatase inhibitors as they respond to the drugs that degrade the estrogen receptor, versus the curve on the right, whereas if you have the normal ESR1 and you don't have the mutation, it doesn't really matter whether you get an aromatase inhibitor or fulvestrant, you do about the same. And this type of information may help us in the near future to guide treatment recommendations. And looking at these mutations was something that was done in the Paloma 3 trial, where patients who had ESR1 mutations, they studied the entire population of Paloma 3, and they found that about 27% of women in this trial had an ESR1 mutation. And that's higher than was initially thought, and it's because really almost all the patients in Paloma 3 were previously treated with an aromatase inhibitor. And we think that it's an aromatase inhibitor that actually drives some of the mutant subclones to grow. And so this is giving us a sense of how frequent this is in the population. But the good news is, whether patients had an ESR1 mutation or not, they still did very well, about the same, when they were treated with fulvestrant plus palbo versus fulvestrant alone. So the ESR1 mutations do not impact response to palbociclib or the cell cycle inhibitors, and that's great. We're looking to make more SERDs, or those drugs that degrade the estrogen receptor, like fulvestrant. We really need more of them. Fulvestrant is an intramuscular injection. It has to be an injection because it's not very soluble in water, and it's placed in an oily-based injection. And there's lots and lots of trials right now that's looking to see if we can make some oral fulvestrant-like drugs so that women could potentially just take a pill and degrade the estrogen receptor and have activity with anti-estrogen therapy in the face of ESR1 mutations. And for patients that are treated at Sloan Kettering, there is an assay that we do here. It's called the MSK-IMPACT assay, where we're actually doing a DNA sequencing panel looking at 410 genes that are thought to be important for cancer. And some of those genes include the ESR1 gene, and others include HER2, which we're going to talk a little bit about. And we're really looking for a change either in the DNA code, or whether there's too many copies of a gene, or whether there's a loss of gene, and whether those types of changes may suggest that a novel drug or clinical trial may be useful for that patient. And really, over the past 2 years, we've sequenced about 1,200 women with metastatic disease, looking at their DNA. And this is just a brief look at what we're learning. We're still really in our infancy, but these green lines here are different mutations, so P53 mutations, PIK3CA mutations. The red lines are amplifications, meaning too many copies of a gene. In triple-negative breast cancer, there are also some genomic alterations. And what we're noticing is actually that in triple-negative breast cancer, they have the greatest number of gene mutations, but those mutant genes may actually make new proteins that may prime women with triple-negative breast cancer to immunotherapy. We may be able to turn the immune system on the cancer if we can recognize those mutant proteins as foreign. And I'll talk a little bit about some immunotherapy trials that are ongoing. We hope to be able to match a patient to a more specific targeted therapy. And sometimes, usually we test a drug, let's say in lung cancer or in colon cancer or in breast cancer. And really now we're trying to do more what we call basket trials, where we take patients, let's say, all with ESR1 mutations or HER2 amplification, and we test a variety of diseases that have just one genomic alteration with one drug, and that's the concept of a basket study. And there are basket trials ongoing at Sloan Kettering. So what's new in HER2-positive breast cancer? Just checking on the time. There are several active agents targeting the HER2 pathway. We have trastuzumab, which is an antibody. We all make antibodies to help us fight infection. And in medicine, we've learned to engineer antibodies to help us fight cancer. So the trastuzumab or Herceptin-based antibody binds to a specific portion of the HER2 protein, and there are too many HER2 proteins in HER2-positive disease. Pertuzumab is a similar antibody that binds to a slightly different part of the antibodies and creates a problem with dimerization. And pertuzumab and trastuzumab can be given together plus chemotherapy and has been shown to be a highly effective combination. We also have tyrosine kinase inhibitors. We have here neratinib and lapatinib that are tyrosine kinase inhibitors that shut down HER2, but at a different portion. And these are really small molecules. They're not antibodies. And they're really just engineered drugs to stop downstream signaling through the HER2 pathway. And then we have a drug like TDM1, which is a very interesting antibody drug conjugate where we're using trastuzumab or Herceptin as this antibody backbone that's then linked to chemotherapy. DM1 is a type of chemo, so it's an antibody drug conjugate. And I always think of TDM1 or the Herceptin as being used as a smart bomb or a carrier molecule that brings chemotherapy to HER2-positive cells. And therefore, you could give less Herceptin and you can give less chemotherapy because it's really a better targeted delivery way to do it. And so these are really the drugs that we're using right now to treat HER2-positive disease. Although in the United States, we have Herceptin, we have pertuzumab, we have TDM1. Lots of places around the world actually don't have these drugs. And many of these drugs are expensive and under patent. And so one interesting study that came out of ASCO this year was the Heritage study, which actually tested a Herceptin biosimilar. So it's not generic, but it's kind of similar in that another company has developed a similar drug, and they're testing whether this activity may be comparable to Herceptin. And we really need this so that we can deliver targeted, effective treatment around the world. And it was a study that really looked at, it's a myelin compound, so MYL14010, so a biosimilar of Herceptin versus Herceptin. And the good news is these drugs are very similar. This is really a major step forward to bringing Herceptin-like drugs to other parts of the country. And I'm just going to move forward so that we have time to touch base on triple-negative breast cancer and leave some time for questioning. So triple-negative breast cancer is a type of breast cancer where we do not have staining of either the estrogen receptor, the progesterone receptor, or HER2. So there's no real brown areas of staining on these three pictures. There are lots of options for chemotherapy for this type of disease. We have many chemotherapeutic agents. We have doxorubicin that we use a lot. We have paclitaxel. We have capecitabine, which is Xeloda. We have gemcitabine, vinorelbine, eribulin, and there are really many other chemotherapies. But I think many of us are hoping that we'll find the right targeted therapy for patients with triple-negative breast cancer. One interesting drug on the horizon is IMU-132, and this is an antibody-drug conjugate. So similar to TDM1, this antibody recognizes a protein on the surface of a triple-negative breast cancer, and that protein is TROP2. And this is an antigen or a protein that's expressed in about 80% of triple-negative breast cancer. And so patients in this trial have a test to see if they have TROP2 expression on the surface of their triple-negative breast cancer. And this is an antibody that's conjugated to chemotherapy called SN38, which is the active metabolite of irinotecan, which is a drug that's FDA approved in colon cancer and definitely has activity in breast cancer. And there are phase 1 and 2 trials ongoing, actually across several tumor types. And this drug, also called sacituzumab govitecan, has been given breakthrough designation by the FDA for the treatment of triple-negative breast cancer. And there are studies that are ongoing looking at the activity of this drug. And this was an early report of only 60 patients. But you can see here, this is a waterfall plot. And again, each line coming down like a waterfall represents a patient. And if they've surpassed that 30% shrinkage in their cancer, they've had a partial response to treatment. And the overall response rate is 31%. So about 30 out of 100 women would have a major response to treatment. And the clinical benefit rate, which is the number of women that are doing well after 6 months, whether they've had major shrinkage or not, is 45%. This drug has some side effects that are similar to chemotherapy, like neutropenia and a low risk of diarrhea, but overall was relatively well tolerated and is promising, and work is ongoing. We know all triple-negative breast cancer is not alike, and I suspect Tiffany Traina has spoken to you guys about a very interesting subtype of triple-negative breast cancer. They tend to cluster with ER-positive disease, and that's because they express the androgen receptor. So just like prostate cancer is androgen receptor positive, it turns out that a subset of triple-negative breast cancer, although it's estrogen receptor negative, expresses the androgen receptor. And there's many drugs that are already used in prostate cancer which try to shut down signaling through the androgen receptor. And there's a lot of enthusiasm about this subtype of AR-positive breast cancer. We are testing both drugs that are used in prostate cancer as well as some novel agents. And there are many clinical trials that are ongoing in this subtype. I wanted to just touch briefly on immunotherapy. There's been a lot of enthusiasm and tremendous advances with immunotherapy in other diseases such as melanoma and non-small cell lung cancer and now renal cancer. And there's definitely interest to look at breast cancer, and particularly triple-negative breast cancer. Because as I mentioned, there are a lot of mutations in the DNA in triple-negative breast cancer. And that scrambled DNA still works hard to make proteins. But the proteins that are made are erroneous. They don't really work. But they're foreign because they're new. And the goal is to get our body to see these proteins, these aberrant proteins, as foreign so that we can convince our immune system to potentially attack the breast cancer that we have in our body. And so therefore there's been a lot of emphasis on whether immunotherapy may be active in triple-negative breast cancer. See, here's the breast cancer, and they call this the mutational load. And it's really a measure of the aberrant proteins that are expressed in triple-negative breast cancer. And one trial that has reported is a study of pembrolizumab, which is one of those checkpoint inhibitors. Pembrolizumab is already approved in non-small cell lung cancer, and this is a result of the KEYNOTE-012 study in triple-negative breast cancer that was reported by Rita Nanda and now published, not at ASCO this year, but there's still work ongoing. And you can see another waterfall plot where these women had significant shrinkage of their tumors in response to just immunotherapy alone. And this is what we call a spider plot on the right. You can see the legs of a spider. And each one, again, represents a patient. And you can see when the lines come down, these are the patients who have had the dramatic shrinkage in their tumors. And these responses tend to be durable in that they can last for a long time. So I wanted to leave some time for questions. I think that this is a time of great promise. I think that there's lots of work that's ongoing, not only to understand the science behind why cancers grow despite our treatment, but we're honing down on the genetic code, looking for certain mutations that are either turned on or that certain important pathways may be inadvertently turned off. And then once we find these genomic alterations, we're trying to match the patient to the drug. This is still an evolving process. We are not there 100%, but there's a big effort to improve upon our ability to do this. And I do think it holds a lot of promise for the future of breast cancer. So I'd like to thank you guys and turn it back to Christine for questions.
Thank you, Dr. Dickler. So I'd just like to read a comment that someone wrote. Kudos to Dr. Dickler. She has helped me understand so much. She's a good explainer. And I'd have to...
Oh, thank you.
So there are lots of questions about the Abemaciclib trial and about the drug itself. Has it received breakthrough therapy designation? And if it has, can you explain what that means?
Yes, so Abemaciclib has received breakthrough designation, which is kind of a fast track to FDA approval, although there are still certain milestones that a drug, must reach. For Palbociclib, that also had breakthrough designation. That's probably in part why the Paloma 1 data was sufficient to grant its approval. Should it get approval, it's all very dependent upon that approval being validated or verified in subsequent trials. And that's why the Paloma 2 trial was so important at ASCO this year, because it really backed up the Paloma 1 study, which had initially led to the early FDA approval. So it's a mechanism by which companies can work more closely with the FDA to generally fast-track their drugs, hopefully get approval earlier than they would have otherwise, but then on the post-approval, they're really required to verify and validate their findings and make sure that their drug is safe and effective.
And can you talk a little bit about how it differs from Palbo? Someone is asking about if the white blood cell count is affected in the same way.
Right. So, you know, these drugs are all a little bit different, and CDK4 and CDK6 are the targets of both Palbociclib and Abemaciclib, as well as ribociclib. And it looks like Abemaciclib more potently inhibits CDK4 than CDK6. And CDK6 looks like it's important for hematopoiesis, meaning our ability to make our white cells. So Abema's hit to the cell cycle in our bone marrow is a little bit less than Palbo, so there is less neutropenia. So that's a nice thing. There still is some neutropenia. You know, I think it was a lower percentage. I don't know off the top of my head. There was still some grade 3, 4 neutropenia, but it may have only been on the order of 20% versus 50% with Palbo. However, Abema has diarrhea. We're unclear why Abemaciclib has diarrhea. It's unclear whether it's because of the differential inhibition of CDK4 versus CDK6, or whether it has to do with the formulation of the drug. A lot of work is ongoing to try and address the diarrhea with Abema, including some trials that is starting Imodium with start of treatment. And the randomized phase 3s that are ongoing are not looking at Abema at 200 milligrams twice a day, but are actually looking at it at a slightly lower dose in combination with anti-estrogen therapy.
And do you think that this might be an option for heavily pre-treated patients?
Yes, I do. That's really what MONARCH 1 showed. All of those patients had to have had prior anti-estrogen therapy and felt to no longer be a candidate for anti-estrogen therapy. And they also had to have at least one chemotherapy in the metastatic setting, no more than 2, but half of the population had already had 2 chemos in the metastatic setting, and everybody had to previously been treated with a taxane, like paclitaxel or docetaxel. I do think that Eli Lilly is considering a compassionate use program, so you might want to look on the Lilly website to see how that's going. Compassionate use isn't easy, but there often is a mechanism where patients can potentially get the drug before it's FDA approved.
And is the trial enrolling hormone-positive metastatic breast cancer patients only?
Yes, actually, preclinical models suggest that all of the cell cycle inhibitors really work best in patients with hormone receptor positive breast cancer. You can be HER2 positive as well, because as it turns out, ER positive, HER2 positive disease may be responsive as well. But these drugs do not appear to have much activity in the triple negative population.
And in reading a little bit about this drug, it said it may be used for first-line brain mets. Is that true?
Yes. So there's definite interest. I don't know if the clinical trial is in first line for brain metastases, but there is a study specifically looking at Abemaciclib for treatment of brain metastases, since this drug is able to penetrate the blood-brain barrier.
So if there's progression on one CDK inhibitor like Palbo, would it make sense to try this when it's approved?
Great question. We're really unsure if there is activity of a cell cycle inhibitor after prior treatment and progression on another. There is a clinical trial it's a small phase 2 study looking at ribociclib in patients who have progressed on a prior cell cycle inhibitor. If that looks promising, I suspect a larger randomized study may be designed. But at the present time, there's no data to say that continuing a cell cycle inhibitor or switching from one to another after progression really makes sense.
What about trials, immunotherapy trials in ER-positive breast cancer?
So they have been done. Response rates have been a little bit lower than in triple-negative breast cancer. Really, immunotherapy has shown some promise, but it has not risen to the level of success that has been seen in other cancers. But there are many trials ongoing. There are even immunotherapy trials ongoing in patients with brain metastases in combination with radiation. There's immunotherapy trials in combination with cisplatin-based agents and or for patients who are getting radiation. So, you have to get on clinicaltrials.gov and or have your doctor maybe help find if a trial is right for you. But, we're still in the investigational stages. I don't think we're near approval yet at all in breast cancer, but work is ongoing in all subtypes.
And there's another resource to find trials for metastatic disease called Metastatic Trial Search. It's a part of breastcancertrials.org, and those are trials specifically dedicated to metastatic breast cancer. It's a little easier to navigate than the government site. We have time for a couple more questions. Any update on PARP inhibitors for BRCA-mutated disease?
PARP inhibitors, well, updated data, not yet, not from ASCO. Trials are ongoing. They definitely have promise in patients with BRCA1 and 2 mutations, but there was no new data presented.
And anything you can recall about the treatment of inflammatory breast cancer?
So inflammatory breast cancer is an early stage of breast cancer. Sometimes women have metastatic disease when they're initially presented, but many just have, an inflamed or red breast that looks infected. At the present time, if you're HER2 positive, anti-HER2 therapy can be helpful in combination with chemotherapy, but really the mainstay for inflammatory breast cancer is still chemotherapy. Early trials looking at bevacizumab showed some promise in inflammatory breast cancer, but right now there is nothing that's new in that regard. But participating in clinical trials would be very important.
Okay, I'm just sorting through. Someone's asking about PD-1 blockers.
So PD-1 blockers are immunotherapies, right? So that's really part of the immunotherapy trials. There are checkpoints also in our immune response. Really our bodies are very complicated. We've talked a little bit about reinstating the checkpoint with cell cycle inhibitors, putting back stop signs to halt progression of the cancer. And the PD-1 and PD-L1 antibodies essentially do the same thing. They reinstate the brakes and or step on the gas for the immune system. And it turns out we thought for many, many, many years that the immune system might be a powerful way to treat cancer, but we really didn't understand all of the circuitry of the immune system and how to break tolerance. And that's what the immunotherapy trials are doing, and that's what the PD-1 blockers are doing.
So last question, and you've been so gracious to answer all these questions. This is a little bit off the topic, but we here at SHARE get lots of calls about this, and I know patients are very concerned about it. So patients that are currently on Palbo do have problems with white blood counts and often have to postpone treatment, and that's very concerning. How do you is there a way to bring the white blood cell count level up faster, I guess?
Well, it depends. I think that you really, generally palbociclib is given 21 days on and 7 days off, so that everybody needs that 1 week break. For some, there's really more profound lowering of the white blood cell count that lasts longer. Generally, if someone has prolonged lowering of their white count, we will dose reduce. So the approved dose is 125, but we sometimes give 100 or 75 as needed. For someone that really has, prolonged neutropenia, I might give 1 injection or 1 dose of Neupogen, but I rarely use Neupogen in this setting. There's nothing really that the patient can do. It's not something that you can eat or exercise that is really going to solve the problem. If the myelosuppression or lowering of the white count really is just too low to allow continued treatment, then abemaciclib might be a good alternative, manageable diarrhea but less myelosuppression. And and it is important likely to continue taking the drug. You really want continuous inhibition of the target. So it does present a problem when counts are so low. And I think that it's something that needs to be watched carefully. With that said, there's always a lot of interest in alternate scheduling. We're not sure if the off period is really dangerous. There's no data to say it is. We know that sometimes hitting the target all the time in other circumstances may create a time when people develop resistance faster. So, we're really learning about these drugs and whether continuous inhibition is needed versus alternate scheduling. We're not sure. We're going to see results of ribociclib trials and abemaciclib randomized studies, and that may help us to determine which cell cycle inhibitor is best.
Thank you so much. And let me just close with this comment that someone wrote. I strongly concur with the other commenter that Dr. Dickler's presentation was great. The best explanations I've heard or read on different types of breast cancer and how different drugs work. So thank you so much.
Oh, you're very welcome.
Thanks, everyone. If you could fill out the evaluation form at the end of the webinar, that would be fantastic. We appreciate it. We always try to improve our services. Dr. Dickler, thank you so much. It was a really informative program, a lot of great feedback, and thank you so much for your time and your expertise. Appreciate
Absolutely.
it.
Anytime, and I wish everybody well. Take care.
Thank you. Bye-bye.
Bye-bye.